Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome. This is Pregnancy to Parenting. I'm Kawa Solomon and thank you so much for joining us once again. We speak to Dr. Malika van der Skype, obstetrician and gynecologist practicing out in the southern suburbs, Constantiaberg and Rondebosch Medical Center. We conclude with trimester 1, yes, the first little bits of your pregnancy, and we talk where we left off last week with regards to the dangers and miscarriages, and inshallah in this episode we will also deal with the second trimester. Assalamu alaikum to you, doctor, and welcome back.
Wa alaikum assalam wa rahmatullahi wa barakatuh. Only a pleasure.
So we looked at last week's first trimester.
Yes.
Just before we continue exactly where we left off, just concisely get us through the actual first trimester. What happens? We spoke about the scans, the visits, what you need to know, what you don't need to know, the diets, and all of that.
Absolutely. So just the summary and kind of concise, the first trimester we said is the first 12 completed weeks or 13 weeks. So it's a third of this pregnancy starting. And we were discussing about figuring out that you're pregnant immediately, often after you've skipped your first period. Some patients where their cycle is not regular, they might figure it out later. As I was saying earlier, going to the doctor or getting your first consultation, often anywhere between 6 to 8 weeks is reasonable, but check with the gynecologist when they're able to see you, when they're comfortable to see you as well. And then we did run through exactly what you could see, that as early as 4 to 5 weeks, when you are only about 5 millimeters, that little conceptus, and that fetus at 5 millimeters already would have a heartbeat. And that you can sometimes see, as we were joking last week, that everything was about food. It was a little peppercorn or lentil, and that it can definitely then increase to looking like a little grain of rice, which is often around end of 6, beginning of 7 weeks, if it looks like that. Then they tend to look like little, at 8 weeks when the baby is roughly about 2 centimeters, we can actually see that they look like little butter beans. Yes, absolutely.
Even an eye.
Yes.
Little black dot.
Yes, with a little butt with where the head and the body looks as though it's the same kind of same size and shape. And then that you then start with little limb buds, so they look like little jelly babies, and then the little skeleton picture of that we see up until we get to about 13 weeks. And that, you know, we were discussing the fact that feeling miserable and nauseous and pregnant and breast tenderness and exhaustion and possibly fainting and that are all the beginning symptoms that could alert you, and that in those who are really lucky, nausea may stay away, but in those who aren't, it can carry on right through to the first trimester, and often from about 10 weeks onwards would start to decrease, and then definitely that there are those unlucky few where it continues right up until the end of the pregnancy. And hopefully those are fewer people than rather the exception rather than the rule. And that basically multivitamins, the do's and don'ts of pregnancy that we did.
Great. So you are now, your first trimester is exactly 12 weeks. That is all the first trimester. First, second, and 3 trimesters, inshallah. That's what we will get through. Within the first trimester, there is also the big miscarriage that happens.
Absolutely.
So that's where we ended off last week, looking at that, the danger signs of the miscarriage, the whole procedure, the whole emergency that you took us through, just to recap on that.
And often patients would ask, when should I tell?
Yes.
You know, because you want to kind of share this news and this joy, but you want to kind of wait until you are okay. So some patients will actually, and safe, some patients will actually wait till they're well into the second trimester and just about showing. And some patients, I would recommend sometimes that you actually just wait till about, the earliest I would say is wait till double figures, 10, 11, 12 weeks, establishing on scan that everything is correct, because that pregnancy, especially in the first trimester, miscarriages can happen and pregnancy loss can happen throughout the pregnancy, obviously, but the first trimester is where the biggest danger is. And that what would alert you is actually terrible cramps, and often patients will be quite worried when they just have the slight niggle or slight cramp or slight awareness of your uterus or period kind of menstrual cramp, that in itself can be normal. It's often the debilitating cramps with really severe backache and bad cramps associated with bleeding. Obviously, the number one thing that women will know is if they bleed, it's, oh my goodness, am I having a miscarriage? And bleeding and pain are usually quite bad signs, and excessive bleeding and pain are, signs that need to be sorted. And often, for example, my patients would know if there is any bleeding or excessive pain or excessive cramps that you think would be out of keeping or not able to tolerate. That is when you need to present yourself either to your emergency room or to your doctor in order to assess, is everything fine? And then, as I've mentioned just at the end of last time's program, is that it is based on that scan, based on the assessment of your cervix, the degree of bleeding, and whether or not, what type of miscarriage it might be.
Okay, that's interesting. I didn't know that there was different types of miscarriages as well. I was exposed only to one with regards to blood groups between yourself and your partner. Please take us through that.
Yes.
As well.
So, just establishing firstly whether or not you are experiencing or going through a miscarriage. You can have bleeding and a little bit of cramps of that, but sometimes patients will present with only bleeding, and when we scan, everything is fine and the mouth of the womb is still closed. So it hasn't opened in order to kind of expel that fetus or pregnancy, and that would be called a threatened miscarriage. And that is when when we are absolutely strict with the patient, where, as I mentioned before, you say bed rest, absolutely no romantic evenings, no sex, no heavy lifting, no strenuous work. So we book the patient, legs up and all of that, and we often look out for infections where that's concerned. The unfortunate rest of the stages of miscarriage is either that you've had an inevitable, an incomplete or complete miscarriage. And inevitable meaning that you have now come, irrespective of what we're seeing, you are pouring, your clots, pieces, cramps and pains, that mouth of the womb is open, that pregnancy is being expelled. And that is kind of inevitable. And you can either have, some patients will come and actually say, oh, this happened a few days ago or a few hours ago, and now the bleeding has gotten less. So you might sometimes be able to completely expel because at that stage we call it the products of conception, that you'd expel that completely and not need any further action. Or you could have an incomplete or inevitable miscarriage where some of those products are kind of trying to come out, but not everything has come out. And often it would be what's left is often the membranes that might be left. And those are the situations which become your emergency situations, where the patient might be in extreme pain, might have fainted, is bleeding quite a lot, would need a drip or an IV line, and probably would need a womb scrape or an evacuation of uterus as a matter of urgency.
With every miscarriage, is there always a womb scrape?
Not always. Sometimes, inevitably, it would be to try and clear or cleanse the lining of that uterus and get all the product out. But certain miscarriages, and often those that happen later in the second trimester, that can be complete when everything has been released and the doctor can examine everything and see that everything has come out. Or in the very early stage, when it's still early, often less than about 6 weeks, you sometimes can expel everything, but often anywhere between 6 and 12 or 6 and 14 weeks, it's difficult to gauge, but ideally between those stages, not everything would come out. Membranes might stay behind. And obviously the risk of that is infection, because if you don't treat that well enough, that tissue is no longer viable. That is ideally dead. It's dead tissue, and that can get infected very quickly and can result in you potentially losing the uterus and becoming a septic miscarriage. So that's why we sometimes end up doing our womb scrapes, and we're so fast to do that, because your bleeding can be continuous and not stop if you don't get that uterus to contract down or clear the uterus of that product.
Okay. Now, often you hear these women that have continuous miscarriages.
Absolutely.
People have a miscarriage.
Yes.
What is that?
Those kind of habitual miscarriages, and we're being very polite in using the word miscarriage. The correct clinical term is abortion, not therapeutic, but we'll say inevitable abortion, complete abortion. Habitual abortion is often the word that they use there, and in your mind you're thinking, oh my goodness, is somebody going to a clinic or thing, but actually it's our clinical term for continuous miscarriages or pregnancy loss. So yes, there are patients, and it's the statistics for women who have had miscarriages are huge. That it's thought that most women, over 75% of women, may end up having a miscarriage at one point or another. Some of them without even knowing that they've had it. You may not know that you were just very early pregnant, you were a week late, you think that the cycle is crampier and heavier, and then you bleed. So that can happen quite often. Those who suffer from miscarriages continuously, there are various causes that we look at. And one of them would be looking at maternal causes. Are you very ill? Are there any other comorbid diseases? Thyroid disease? Is there potentially something that we call an autoimmune disease, where you fight your own body and you actually form antibodies to cells within your own body? And those can be these big conditions like systemic lupus erythematosus or lupus. It can also be conditions like antiphospholipid syndromes. Those are things where the blood is either too thick or the connective tissue is too thick, and you don't get that implantation. There is a huge number of causes. Sometimes it can happen in the second trimester because that cervix is incompetent or it doesn't, work. And as you'd mentioned earlier, it can sometimes happen with regard to an incompatible blood group, where that's concerned. So those in the incompatible blood group would be you are rhesus negative. It doesn't matter if your blood group is A, B, or O, or AB. You are rhesus negative. You do not have the rhesus factor, but your partner or your husband does, and the child has genetically gotten that blood group. And if a little bit of that rhesus factor gets in your bloodstream, your body's not been exposed to it, so it forms antibodies against it. So you're fighting off that blood. But we must remember these are two separate systems, so it doesn't always get into your bloodstream, but it does after a birth, and it can after a miscarriage. So that's why that injection is so vitally important that you get if the mother is rhesus negative. So if the mother's rhesus negative, she doesn't have the rhesus factor, she gets exposed to that blood group which is rhesus positive, she can form antibodies. But there is an injection to prevent that.
I want to talk about the injection.
Absolutely.
More on miscarriage within the first trimester, and then after that, stay tuned for details on just starting off with the second trimester. Back in a moment on Pregnancy to Parenting. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back. This is Pregnancy to Parenting. With me is Dr. Malika Van, obstetrician and gynecologist practicing out in the southern suburbs here in Cape Town. Shukran and welcome back, Dr. Malika. And also big shukran for having us here at your Ronda washrooms as well.
Only a pleasure.
Alright, just before the break we looked at miscarriages, why they happen, what we can do to prevent it, we're going to look at now. And then just before the break as well, you chatted to us about this injection. So this is new to the talk now.
I mean, we will go into the different blood tests that need to be done, but most women will know it is absolutely vital to know your blood group.
Okay.
And your blood group will be a plus, with an addition rhesus factor, a plus or minus. So you're either going to be O positive or O negative, A positive, A negative, B positive, B negative, or AB positive or negative. So what is vital for us often to know is whether your blood, that rhesus factor is positive or negative. And
what does rhesus mean?
Yeah,
rhesus.
The rhesus factor is in your blood, and it's very scientific and clinical. So just to get to it, it's that if you are rhesus positive, you have the rhesus factor in your blood, and you've been exposed to it, you have it, it's in your bloodstream, it's circulating around. Yet, if you're rhesus negative, your bloodstream has never been exposed to it. So that's why when they talk about universal donors and universal recipients for blood groups and things like that. So when a woman is rhesus negative, which she's inherited, this is now, and she does not have the rhesus factor. If her partner or husband is rhesus positive, and as that egg and sperm have gotten together and fertilization takes place and that baby's blood group is getting determined, inshallah, it ends up being positive or negative. So if the mother is rhesus negative and the baby is rhesus positive, and those are two totally separate systems, luckily, even although it sounds difficult, but you have the uterus, you have the placenta, and in between that uterus and placenta with their implantations is your actual filtering system. So that is filtering that. So your blood and baby's blood is theoretically never mixing, which, you know that you're attached to this baby, you feel everything, but actually they're two separate circulatory systems, and you've got that middle as your filtering system, that placenta and all of that. So if when either once you have given birth, when there is bleeding happening, irrespective of how you give birth, vaginally or via cesarean section, or if they used instruments or not, some of that baby's blood can get into your bloodstream. Or if there has been a miscarriage, as we were just discussing, or if there's been a bleed in the pregnancy as well, some of that can get into your blood. So you now do not have the rhesus factor, but there are these little aliens swirling around that are this rhesus positive blood. Your body forms antibodies to it. In your next pregnancy, if that baby is rhesus positive as well, you form an antibody to the baby because you recognize it as a alien or germ or something that has been invading your body. So you fight it off. And that's often where the miscarriages take place, or the baby doesn't grow well, or it's called rhesus isoimmunization. And alhamdulillah, we don't see it that often because we get very good with knowing that within 72 hours of that birth, or within 72 hours of that, so we have time of having had that miscarriage and we know your blood group, you can have an injection. An anti-D or ROGAM injection, which tries to help and coat your body, those blood vessels, and tries to protect you from forming antibodies. Because if you do, what happens is each pregnancy can get affected, and it can get affected at various stages of the development. So it can be in the first trimester with miscarriages, the second trimester with second trimester losses, or stillbirths in the late second trimester, or stillbirths when baby's born, or babies that are born severely because your baby's fighting off this and the blood it's getting is tainted, so to speak. They get a form of anemia in the womb, and they get heart failure, anemia, and there are various complicated things we can do to try and treat that, but it is quite a dire and serious situation. So that's why I always say to patients, it doesn't matter if you don't remember the exact blood group. You don't know, are you B positive or are you A positive, but know that you're that positive. Is it positive? Am I negative or positive where that rhesus factor is concerned? Because, as you were mentioning from personal experience, that can be something that can contribute towards pregnancy loss.
Right. Taken all of that in.
Absolutely, and that's just one of the causes of miscarriages. We could have an entire series just on miscarriages.
But inshallah, Dr. Malika, shukran so much for that. Now I want to move on to looking at how we can prevent the dangers of miscarriage if it is in your history.
I want to start right at the beginning to say a lot of people really believe that stress has a big part to play in this. And it's very simple for me to say, try not to stress in your pregnancy. And I hate using this. My patients who know me will laugh because I keep repeating this. I hate using stress as a diagnosis, but I also can't ignore that it is a valid, dilemma. And I think, a pregnancy is very strong and resilient. I think doing your multivitamins, your folic acids early, not getting yourself into a situation where excessive toxins, drugs, alcohol, those things could contribute. Look at the medications that you're taking. Those are just things you can do to kind of prevent where that's concerned. Sometimes miscarriages are inevitable. It was meant to happen irrespective of what happens. The pregnancy might have been compromised, as in it's not growing well, but a shock to your system triggers the miscarriage. But it often triggers a miscarriage in a pregnancy that's already was not healthy, or viable, because women who are extremely ill, women who are riddled with active diseases like TB or HIV or untreated, or women who fall pregnant under situations of high stress or are in war-torn areas or areas where they are malnourished, some of those pregnancies, alhamdulillah, can survive. So a woman who have had no multivitamins and everything goes fine, and you think, alhamdulillah, it's a miracle, everything's gone fine. But sometimes don't blame yourself too much is one of the vital things I want to say also, because often it's a pregnancy that was already not growing or growing well. So I think obviously health, not hectic physical strain, lifting up extremely heavy things, excessive physical strain where that's concerned, treating anything that you think is wrong, as in go and seek help if you think there's infection. Do not ignore bleeding, and don't ignore that if you've had bleeding, you've come to the rooms, we've scanned you, everything's fine, and now you think, okay, I'm going to go back to work and climb 3 flights of stairs, run around to the copier or to the machine all the time and things. Take that advice of no bed rest where that's concerned. Don't hesitate. I know nobody loves sitting in the doctor's office all the time. Nobody likes feeling like they're crying wolf or things like that. But if you are worried or alerted about something, do not hesitate to contact and sort it out. We should ideally be saying to you, okay, fine, let's check everything's fine. Our ultrasound at that stage is our best guide for trying to see and assessing that everything truly is fine. So I think knowing your dates, going for your scans early to check out viability, we should establish that we are ultimately happy with your growth, with the dates. Does it equal the scan, as I mentioned before? And also, do not ignore bleeding. Yes, sometimes we spoke about this before, that sometimes you can have the odd bleeds in the pregnancy and you think, I don't want to keep alerting the doctor, but rather feel as though you're being, I know, but rather think like that, but know that you've been reassured.
Pregnancy is very,
absolutely,
very
it can be,
beautiful,
and it can be quite fragile.
So there's often you get on the chair or you just take a step in the kitchen and you take on the stepper, getting some groceries off or a blanket off and you stretch out, and you jump off, you don't realize that you're jumping, all things like that. You just have to be aware of you're doing certain actions. Just move around slowly. And you are a little bit older.
Absolutely, and these pregnancies are vital, and especially if you, as I've mentioned before, if you're high risk, age-wise if you're high risk, health-wise if you're high risk, if there's been any bleeding before if you're high risk, do not hesitate to get that, sorted and dealt with, quite soon. Because obviously miscarriages are devastating events, and there are events where the patient and the woman often is looking for something, a sign or an idea of, was it my fault? I didn't wear my socks. I went out when it was really cold. I did this on that day. I got upset. I yelled at my husband. I was upset at my mother-in-law. Something like that. And you're thinking all of those things. So there's a lot, and I can be as supportive and say, I don't think you should blame yourself, but often women do anyways. Yeah.
So talking about that wretched turmoil that you do go through, that psychological upset, how can we maybe guide our partners or the family to help that person, that woman that's going through that very trying moment in her life?
Absolutely. I think our society wants to be so helpful. And our families, our mothers, the woman we know, everybody wants to be so helpful. Yet sometimes you don't realize that you're really not being, so kind of going, yeah, you see, you're not supposed to be wearing high heels, or you see, you did this because
put on your long pants.
Yes, or just give some guidance. And also, that statement, you people are young, you've got your whole lives ahead of you, don't worry about this. It is a loss. You need to mourn a loss, and you need to not be made to feel that just because it was 8 weeks or less than 2 centimeters, it wasn't a valid loss. And I think this is where I like to bring the partners in, because we often don't realize that they suffer the loss as well, and they are often so ever present to their wives and partners that they don't take time to mourn or grieve, and nobody bothers to ask the husband, dude, are you okay? Is everything fine? How do you feel about all of this? Because, you're also going through those clinical, sometimes you don't have time to even feel like that, because you're going through having to have a procedure, and then afterwards,
This all happening.
Yes, and also, sometimes I also want to say, grieve the loss. Don't just think, when can I be pregnant again? When is the next time? Let me do a replacement pregnancy and get over this.
All right, inshallah. Hopefully everybody or anybody that has experience will recognize it and have the necessary support around it. Please, be cognizant of that and mourn that. Take the time out, whether it be both for, the man or the female.
And also just realize there are support groups. There are people who get together and talk about their loss to somebody else if they can't find that person in the community, in their family, or their friend circle that can guide them where that's concerned.
Inshallah, we hope that they are guided in the right direction, inshallah. After the break, we hopefully deal now with the second trimester. If you've missed any, we were just talking about the first trimester and the dangers and the miscarriages. Yes, it does also happen within the second trimester, but we're going to deal with that all after the break. Please stay with us. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back. This is Pregnancy to Parenting. Shukran so much for joining us. I'm Hawa Solomon. With me once again is Dr. Malika Van obstetrician and gynecologist. Doctor, we ended off now with miscarriage, and I'm hoping that that has encompassed all of it, and I'm sure there's lots more to know about it, inshallah. But moving on now from the first trimester to the second trimester, I believe there is a fetal abnormality scan that needs to be done just before your second trimester.
There are, yes, and that is just at the precipice, just at the end of the first and beginning of the second trimester. There are, and your doctor will perform lots of different scans. For example, some of us will scan you every single visit, try and give you pretty pictures, listen to the heart rate. Later on, your scans are much more about your growth and things like that. Right in the beginning of the first trimester, it's mostly about viability. Is it in the correct place? Is the growth looking all right? So most of your first trimester is about viability. But between 11 and 13 weeks is a very important vital time that has been designed, so to speak, to try and exclude fetal abnormalities, mostly with regard to Down syndrome. So there are two special fetal abnormality scans that can happen in a pregnancy. The first trimester one, right at the end of the first trimester, beginning of the second, and one smack bang in the middle of the pregnancy, which is more of a detailed fetal abnormality scan that we can get to later. But the first trimester one has been designed this early on by those who are looking out for Down syndrome, particularly. Those syndromes like Down syndrome, which is trisomy 21, which is an abnormality of those chromosomes, where they end up being in 3 different pairs. So it's trisomy 21, which is Down syndrome, there's trisomy 18, and there's trisomy 13 that we look out for. So, and those abnormalities can be detrimental in the pregnancy because, well, it can alert you to the fact that you might have a Down syndrome baby or special needs child. And some of the other ones, like your trisomy 13 and trisomy 18, can often result in stillbirths, second trimester miscarriages, or when the baby is born, that it can be incompatible with a long life. And that, they may end up having neonatal deaths or demises. So the test is designed, it's a two-phase thing. It involves, it's a non-invasive test. It's an ultrasound scan. So they are not doing anything internal, they're just scanning on the abdomen, and it's designed to try and figure out who is at high risk and who is at low risk. So that those who are at low risk do not need to unnecessarily be exposed to an amnio. Because the minute I talk to somebody about Down syndrome testing, they say, oh goodness, I don't want an amnio, I don't want somebody to stick needles in the abdomen and things. And I'll explain that later on. But to explain it, what I do is, I recommend it to the patients often if they are at high risk of Down syndrome. So back in the day, before this test was designed, a woman who, for example, was 43 or 42 would automatically be at very high risk of Down syndrome. So she would potentially end up having needing to do a diagnostic test. So you would need to stick a needle into the abdomen, take out some fluid or around the baby, so in the amniotic fluid, which has the baby's genetics and cells in those genetics in those cells, in that cellular tissue, and you analyze those out and look at the chromosomes, or you take it from the cord called cordocentesis and you analyze that out. So you're actually analyzing the genetics. It's a definitive test.
But this is the
the risk of the amnio obviously is that you have a percentage chance of miscarriage, and it depends on the person's hands. You can have a 1 to 3% chance of suffering a miscarriage just due to the procedure itself.
What does these procedures?
These procedures often, especially in our town, happen at special fetal assessment units or fetal assessment centers, so that those who do them constantly, they have to have a criteria. The patients are absolutely counseled. But now, before we even get to that kind of invasive test, the non-invasive ones have been designed to try and be as sensitive and as specific for up to 96 to 97% sensitivity and specificity. So trying to accurately only do those that you deem are ultimately necessary where amnios are concerned. It also gives you a wealth of information. So it's called a nuchal thickness scan, or your first trimester scan. And what it involves is when your child is laying on its back, when it's laying, we measure the thickness behind the neck. Because Down syndrome babies genetically have a thick neck. Down syndrome babies, and it's called Down syndrome because there are many abnormalities that you can have. It's a syndrome of abnormalities, one of which is there is a problem with the heart, with one of the valves. It's called tricuspid incompetence or regurg, and that could also contribute towards heart failure, to contribute towards swelling, which can contribute towards swelling behind the neck. So we don't just judge that. We measure the thickness behind the neck. They look at everything from head to toe. It's a beautiful scan. It's lovely. It's comprehensive. That's not why you're going to have a pretty scan. You're going to look for the information. They look at the heart and the heart chambers. You can have Down syndrome babies who have a short upper arm and they have a short upper leg, so a short humerus or femur. They can have a gap in between the toes called a sandal gap. They can have different kind of signs on their hands. And what happens is we do a blood test. That's about as invasive as we get at 10 weeks, where we look at a placental protein and we look at your pregnancy hormone. And it's not important what that blood test result is exactly at 10 weeks. It's important when you go to a fetal assessment unit and they enter that into the computer. They will put in your age, your ethnicity, weight, family history, previous problems, these blood tests, plus the measurements, and whether or not there are any other positive signs. So they collate and they calculate all of that with a special designed program that through many years of research and things has been designed, and that needs to be continually updated as well, to actually give you a risk ratio. So they would tell you, and I often use this example, for example, a woman who is, say, 42 might be at risk of 1 in 20 or 30 of having Down syndrome. So that's very severe. You know, back in the day, they might have said, okay, fine, let's do an amnio, let's check for sure, are you at risk? But now, she could have that test and come out with a risk of 1 in 2,500, which is actually a low risk. However, so then it's fine, you have scanned low risk on this assessment, on this risk assessment, no further action needed. Or they would counsel you and say, I'm sorry, it's now come back as high risk. We suspect from these signs and what I'm seeing that there might be a problem. The one thing I failed to mention is one of the things they look at that's also vital as part of the calculation is the nasal bone. Because up to 70 to 80% of cases, there is either an absent nasal bone, so it doesn't matter how flat you think your nose is, and how most patients are worried about is the baby's nose flat or not. It is, it's that nasal bone, whether it is too short or whether it's actually absent. That's also a vital part of the risk calculation. So the risk calculation, if it is that you are high risk, they may say to you, you have a 1 in 100 chance of having a Down syndrome baby. They will then counsel you and say, would you like us to perform an amnio? And you can then say, no, alhamdulillah, I'm not interested, or yes, I will.
Is that confirmation that amnio is more?
Is your absolute confirmatory or diagnostic kind of test to see for that abnormality. And you might, your next question, I'm probably preempting your next question. Your next question might be, so what? Why would you want to know that early? Some patients want, nobody wants to get bad news, obviously. It sometimes preempts so that you know ahead of time, so that you can plan, you can emotionally get, prepared for the idea. Some patients and some colleagues might counsel, would you like to terminate the pregnancy or not? That's why this test was designed in the first trimester, because those patients who make decisions like that, it's within that
and you can find
that
it
time.
so early on.
And you can find out that early, and these results are getting faster, because before you would only find out perhaps at 16 weeks, 18 weeks, 20 weeks, that kind of thing. So you can have a guide and an idea. And if there is a problem, why do I need to know this early? Sometimes it gives you the opportunity to kind of get used to the idea emotionally, and that why will you might be thinking, but am I going to be any less upset now than I am going to be later? In a way, yes, because it then means that if it is that there is a special needs child because of something like Down syndrome or any of the others, you can, it's not a complete shock to the system right at the end. You can then be primed and preempted towards it. You can institute treatment early, or physiotherapy, occupational therapy, massage therapies with these babies, or often are quite spastic and tight sometimes. Schooling, counseling, things like that, which can help the child, family support, which can help where that's concerned. So, this test is, I sometimes recommend that you do if you are at risk for age. And some of my patients would say, I'm not going to do anything with the information. I'm not going to have an abortion. Why should I do it? It is sometimes just about that information as well. So that's important, and that's fine. And then, I also just need to say, as I'm saying this, I'm sure there are people out there who are busy saying, oh yeah, but I know somebody who had the whole test and they said everything was fine and it didn't turn out fine and something was still wrong. These are just tests. sometimes they can have a flaw, but they can get as accurate as up to 96, 97% sensitivity and specificity, but I'm not giving you 100% guarantees. It's all in God's hands.
Absolutely. But I think back in the day, my first child, these tests weren't available.
Absolutely.
My last one now, and then you're given all these specialities. Alhamdulillah, it is there available for you, but ultimately the divine is in control.
Yeah.
Inshallah. We'll continue with pregnancy to parenting after this break. Please stay with us. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back. This is Pregnancy to Parenting. In our last segment now, we're finally looking at the roundabouts of the first trimester. And before we kick into the second trimester scans, Dr. Malika will now explain to us with regards to the ending of the first trimester. We just discussed some very grave decisions one needs to make within that ending of the first trimester and looking at the fetal assessment scans. What other tests would you recommend or would be performed just before your second trimester?
So the fetal assessment kind of scan, that first trimester one, I must just say also that the reason why we often recommend you come early is because these units get quite booked up. And if you're in a town where it doesn't happen, just by the way, sometimes it can happen. If it doesn't happen at a special assessment center or clinic or unit, sometimes your doctor is able to do that. And also what I didn't mention is, and thank you for alerting me to that about the tests, is sometimes in the second trimester, there is, if you do not have these facilities available, some of the labs can help with this, where these risk calculations are concerned, and some of the areas which is not a metropolis area, like like Alhamdulillah, your Cape Towns, your Durbans, your Joburgs, where these centers do exist. Out there, what happens is we're doing it in our rooms in rural areas or areas where those centers are not available. But sometimes, if you truly aren't able to, there is also in the second trimester, it's called the triple test kind of thing, where you also can try and find your determination or risk determination regarding Down syndrome or neural tube abnormalities, looking to check, spina bifida, whether that spine has closed or not. All of those, that is a test that can happen between 16 and 20 weeks. It doesn't happen much anymore. And I know when I started at medical school, it was like vital to remember the triple test, and now it's gone to become the quadruple test, because it's now not just 3, there's 4 things that we test as well. So know that if you've missed that, there is also something that can happen in the second trimester. Not as sensitive or specific, as I said, as we've made the first trimester scan and blood test out to be. So know that that is also an option, so that would be tests around fetal abnormalities. As you're heading out of the first or into the second trimester, in and around this time is often when we start doing your antenatal bloods. So your antenatal bloods would be trying to assess your blood group, as I'd mentioned, if you don't already pre-pregnancy know your blood group, or if you're not a blood donor or don't already know, we'd check your blood group, because it'll tell you what your blood group is, that A, that B, that AB or B positive, and then tells you whether or not your rhesus group is positive or negative. And then additionally, it tells you, are there any antibodies there? So if, for example, your rhesus negative, you've had a miscarriage before, or pregnancy before, in your next pregnancy, it's vital for us to check, because if your blood group is rhesus negative, meaning, as I said before, you don't and you have not been exposed to that rhesus factor, and you've had pregnancies before, or in this pregnancy, we will test roughly every 6-ish weeks for the soonest to check, are you forming antibodies against your baby? So that would be the test that would happen, not just in the first trimester and then never again, but throughout the pregnancy. So those a woman will say to you, I kept having to go for bloods because of my blood group. And it tells you about antibodies, and heaven forbid, hopefully there aren't any. And, we love seeing it, she's O negative, no antibodies detected, no antibodies detected. That's what I love reading, and they just tick it off as being happiness. So that's that. The other test, often as part of doing that, sometimes we do your full blood count, which tells us whether you're anemic, what your platelets are doing, white cell count. It tells us about your blood smear. Is there any problems or abnormalities there? That one is not absolutely vital or integral, but it's often part of the antenatal screen. Also can tell you about anemia, which we, will get into in the second trimester, as you suggested. But so that's why we do that. And then come the tests that tell you about infection. So we do check for syphilis. Not a very common infection, nasty, it's sexually transmitted, can be silent, can affect the baby really badly. So that when it does affect the baby, that child gets that congenital infection, and they can end up getting heart failure, anemia, a swollen liver, a swollen spleen as well, and can result in stillbirth, premature births, death, or baby that is infected. So, and it's very easily treated with penicillin if picked up. So this test is quite vital. So you'll often find, as the bare minimum, blood group and syphilis might be one that would just be tested. And that was often in the public sector is what gets tested, as well as HIV nowadays, because it is so prevalent. Because HIV and your HIV status will determine how we deliver baby, what happens, which medications you're on, and obviously it's extremely life-altering, knowing this diagnosis. We also do check hepatitis as well. So we do a hepatitis screen, because that's also, as with HIV, a blood-borne disease, potentially sexually transmitted, although can also be transmitted in, heaven forbid, blood transfusions, but those get tested, drug users, professionals who are in contact with blood all the time. So that's why we check where that's concerned. We counsel you that we're going to check for that, because it's vital that we know that it will change our management and change our medications that we use during the pregnancy. And then lastly, what I had mentioned when we spoke about fertility a few episodes ago is German measles or rubella. Whether or not you are immune or not. Now, out of all of them, there's not much you can do in the pregnancy if you're not immune. So what we do is we do your blood to check, have you either had it before? And as much as most patients don't like having blood drawn, I can't just trust that you say to me, my mother said I had it, I'm sure I'm fine.
You're going to do it anyways.
I know, and we need to check, are you immune? Did you form a sufficient immunity to it? And or were you successfully immunized? And we look at a value, and depending on if that value is above a certain range, to say you're potentially immune or you're susceptible. And even although I'm counseling you and saying you're susceptible to rubella or German measles, there's not much we can do other than say, do not expose yourself, which sounds so easy and so simple to say, but if there are parties or little kiddie birthday parties, find out, and also to parents out there, to be responsible not to take your child out if there's been a contact. And it's responsible for those who are not pregnant to mention to those in their workplace, I have a German measles contact, or, I have German measles, or things like that. And, it's vital because it affects the baby so badly if you get it within a certain time, like when the organs are growing, when everything is still growing, at the end of the first trimester or beginning of the third, beginning of the second trimester is where it really is bad. You can have congenital heart abnormalities, you can have, issues in and around mental impairment or mental retardation. You can have issues around blindness, hearing impairment, that kind of thing. So that's why those diseases are important, that we test for that.
Now, I've often heard that, the whole German measles thing is that okay, I've been in contact with German measles, but my child is now well.
Yes.
So does it matter if you've been in contact with somebody that has just started their German measles sickness or somewhere in the
See,
middle?
the problem is, because
that's what people are saying. No, stay away.
Always,
She's had it for 5-7 days already,
yes,
so it's okay.
Because often when you manifest, meaning those little spots have started, often when you manifest, the infected period was actually anywhere between 7 to 21 days before that, depending on how long it's taken.
Okay.
So you have that incubation period that we talk about. And people will know about that when you deal with chickenpox and other diseases and mumps and measles, and that there's always an incubation period when you're often more infected, and that's where, the joke that we would always go on about is like, no kissing anybody else other than your hubby on the lips, and, good hand hygiene, because that's where you're getting it, you're touching, and, where that's concerned. And my patients would laugh because I'd always say, don't kiss any snotty-nosed children, because, that might be where the
I remember I had to actually incubate my little ones when I was pregnant, and they had German measles. They had to go and sit in the cottage with a domestic, and I had to be in one room share. It was being sad.
And I, we've had pregnancies, for example, where the husband and the kids had chicken pox, and the wife had to be, her mom was a doula and accompanied her, things like that. So, and I'm mentioning we check for the one that is really, really bad, affecting the baby congenitally. So we don't, so measles, mumps, chickenpox are not necessarily the ones we do. We'll check for those when they are, if you have been exposed. And don't worry, if you have been exposed, first check to German measles. Check with your doctor whether or not you're immune, firstly. Secondly, if you're not, or we haven't done the test, go and have the test done, get the result, know whether you should kind of panic or not. So those are pretty comprehensively the tests that we would do. And ideally we wouldn't add too much more unless we are alerted to something. Like, as I mentioned before, if you vomit excessively, we might check your thyroid function to check if you're okay. But those are pretty much all of the tests in the first trimester and the beginning of the second trimester that we would deal with.
So much was happening within the first trimester. We just touched on the tip of the second trimester, which means that we're going to, inshallah, cover it in the next show.
This baby hasn't even kicked yet.
We've gone through 3 shows. Shukran so much, Dr. Malika. Always a pleasure having you here. And shukran for your time. As always, we'll chat to you again in the next episode. Starting off with the second trimester. Wa alaikum salam. Wa alaikum salam wa rahmatullahi wa barakatuh. Shukran so much to Dr. Malika van der Skye, obstetrician and gynecologist practicing here in Cape Town in the southern suburbs. In our next shows, please do stay tuned where we look at the second trimester. Any of your scan issues that you want to know about, your second scans and any abnormalities, also little ailments as well. So please do stay tuned for that. From myself, Hawa Solomon, wassalamu alaikum wa rahmatullahi wa barakatuh.